Welcome to NatRevMD, a podcast where we share tips on optimizing medical billing and improving practice efficiency so you can have the business of your dreams. I'm your host, Dr. Heather Signorelli, founder of NatRevMD. Let's get started. All right. Hey, guys. So what if I told you there is untapped revenue in your practice right now that you could add six figures to your bottom line for every 100 patients you enroll? And what if I told you that that work is probably something you're already doing and it just got easier to bill for this in 2026? And those words are very infrequent for me to say, that CPT code changes actually help you in increasing revenue. So we're going to talk about some CPT code changes specifically for remote patient monitoring. And if you're thinking, gosh, I don't have the ability to do that, or I don't do that right now, listen in to part 1 and part 2 of this episode so that you can identify how those CPT changes have changed, how it makes it easier to bill for this, and that you can actually implement this within your practice. And it's not that difficult to do. And there is some good money to be had, especially if you're any sort of primary care field. And that can include OBGYN. That can include, obviously, a multitude of other subspecialties where you're following patients along for chronic diseases, where you are needing to do some remote monitoring of vital signs or lab values, things that they are potentially already checking at home. So as of January 1st, the rules have changed. And so that barrier to entry when it comes to remote patient monitoring has changed. And so you do have an ability to implement this with a little bit easier timeframes to make that revenue easier. All right. So obviously, you guys know RPM's not new. It's been around for a while. But the billing rules were a little challenging. They were difficult to get at least 20 minutes of monitoring time per month. And so for many busy practices, they just, said, okay, it's a non-starter. I'm not going to do it. But the CPT codes in 2026 just set below that barrier. And so it makes it a little easier to consider doing this. So the new codes allow you to bill for monitoring periods as short as 2 to 15 days. And the time threshold now for treatment management has been basically cut in half, right? So it's gone down from 20 minutes to just 10 minutes. And so this is really a game changer, I think. It means that you can get paid for those short, frequent check-ins that many of your chronic care patients already need and you're already probably doing. And so it just makes it a little bit easier. Today, we're doing kind of a 2-part series with regards to remote patient monitoring. So today in part 1, we're going to cover the foundational kind of basics. We'll cover clinical pieces of why this matters. We'll break down some of those new codes and then the qualification criteria to get this started. Then we will do part 2 next in a couple days, and that will go into kind of more of the details around how to implement. All right. So before we get into the money, let's start with the clinical piece, right? So what is RPM and why should you be doing it in the first place? So obviously, we all know that remote patient monitoring is the use of some sort of digital technology to monitor and capture essentially healthcare data from a patient and then electronically transport that information to a healthcare team. And then they assess it. And then if there is a necessity, right, there's recommendations and instructions on how to manage those values. So these can be things like glucose, it can be things like blood pressure. And we'll talk a little bit about some clinical examples. So for example, right, you have a patient who needs a blood pressure check every single day or a glucometer, or even a weight scale that automatically basically sends the readings to your clinical team. And your team then monitors those readings and then intervenes and calls and talks to the patient about those readings and could potentially say, hey, we need to change your medication, or, worst case scenario, they need to go to the emergency room. They're having a situation that requires immediate attention. So obviously, for a lot of your practices, you may already be doing this, right? The patients may be already noting their blood pressures and they may be already calling into the office. And so really, this is about how can you leverage technology and bill for the care that you're already providing for those patients specific with these chronic conditions. So again, this can be hypertension, diabetes, CHF, where that daily monitoring is going to be really, really critical to avoid those hospital admissions. So again, a lot of this you're already doing. So really today, we're just talking about these CPT code changes so that you could implement this into your practice in 2026 for some increased revenue. Again, that could be 6 figures with just as few as 100 patients. So studies obviously have shown that this is really, really important. I think that's why they're promoting these RPM programs, right? Because it can lead to improved clinical care. It can lead to reductions in admissions. And so that's really the goal here. Personally, from a physician, we all know that, a lot of the work that you guys are already doing are things that you're not getting paid for. And so I really do see these CPT changes as something that helps you bill for those with smaller timeframes and will enable you to increase the revenue in your practice if you're already doing this. Now, having said that, there are some nuances around how to get these patients enrolled, what technology to use, and so forth. And so we'll talk a little bit about that today. Okay, so there are 4 key RPM codes that you need to know. 2 of the old ones and 2 of the new ones. So we're going to treat this like, a family of CPT codes. So first you have the codes for the actual device supply and the data transmission. So these cover the cost of the actual device and the daily monitoring. And so the old standby CPT code was 99454. And don't worry, we'll turn this into a blog as well so that you can just listen and then refer to the blog on our website, natrevmd.com/blog. All right. So this CPT code 99454 is the code for the supply of the device and monitoring for a 30-day period. The key rule here is that you must have had at least 16 days of data transmission from the patient within that 13-day period to bill for it. And that was the struggle, right? Because that's a really long period of time, and maybe you're not needing to do that. Now, this is for those long-term chronic care patients, which you may hit that time period. You may hit more than that 16 days, again, within that 30-day period, but you may not. And so now there's a new code, 99445. This is for short-term monitoring. It covers device supply and data transmission for that period of 2 to 15 days. So that 2-week time period that you may be requesting a patient to measure. So the reimbursement is the same actually, but you can now bill for those short episodic monitoring periods, like just after a surgery or a medication change. And so basically that 16-day rule here does not apply. You just actually technically just need at least 2 days, which is a very big difference between 16. So this is a new code and very, very helpful, again, if you're asking those patients. Next, you have the codes for RPM management. So this is where you're actually billing for the clinical work that your staff is reviewing, right? And so this is the piece where they're reviewing the data in a dashboard or some sort of mechanism by which it's coming over to you. You're communicating with the patient or calling the patient. So the old code, which is still available, is a 99457. So this covers the first 20 minutes of clinical staff time per calendar month. This has been the standard for years. Now, the new code is 99470, and this is for when you don't hit that 20-minute mark, and it covers 10 to 19 minutes of clinical RPM time. So again, you do have to hit that 10-minute mark, but you don't have to be required to hit the 20-minute mark. And so the reimbursement is going to be about 50% of the 99457, but it at least allows you to capture some of the revenue. Again, you're already doing this work. It's just a matter of documenting it and enrolling the patients, which we'll talk about more in part 2. So this is a way for you to have kind of a short-term and a long-term option for both the device billing. Again, that's the 99445 and 99454, and a short-term and long-term option for management, right? So that's the 994 and the 99457. So basically, this is the flexibility that was added in 2026 for that new RPM revenue opportunity, really. So how do you qualify to bill for this? This is an important piece. So this is where the practices can get into trouble, and you want to make sure that you have some nuanced understanding around this. So today we're going to talk a little bit about the CMS guidelines. Again, each payer is going to have slightly different rules around this, but in general, a lot of payers follow CMS. So who can order and bill for RPM? So those are going to have to be ordered by a physician or other qualified healthcare professional. So that's your mid-levels, your PA, your NPs. The service can be billed by the ordering provider. RPM is intended for patients with chronic conditions, but of course, we don't get a fun little list that it gives us a whole list of ICD-10s that qualify for this. But a lot of the examples that I talked about today, hypertension, diabetes, CHF, COPD, obesity, the key here is that the provider must believe that the patient's condition actually requires monitoring to manage it effectively, and that you've documented that in your patient charts, right? So if you get audited or if you have to send in communication around that, you do need to make sure that that is documented. Obviously, patient consent is mandatory. You have to obtain and document a patient consent before initiating RPM services. So you'll want to have a form for that. And they must be informed that they will be responsible for any copays or deductibles. And that's a very big, important piece for this. But again, you're doing the work. You deserve to get paid for it. And I believe that we psych ourselves out. We're like, oh, it's only, this much money. I'm not going to waste my time doing with it. Every little bit counts. And these little things that you're already doing are really, really important to put into place. Again, this is a perfect activity for a mid-level or even an MA to coordinate, or an office manager to help set up and then take that process and delegate to an MA who can help coordinate the process and the data review and the escalation to a physician. And so really, really, this can be a great process. It is a thing to get started, and it is a process. Again, we'll talk about more in part 2, but I think it can be very, very valuable. So to bill for the CPT code of 99454, right, the 16-day rule, you must have at least 16 days of data transmission from that patient in a 30-day period. So obviously documentation is going to be key, and you must document that time spent in your 10-minute check-ins. Obviously, what did you talk about? How did you communicate with the patient? Any changes to the patient's care plan? All of those things are going to be stored in the patient's note, right? And so that is going to be the key to being able to defend any sort of RPM billing audit. All right. So we are going to do an additional part 2 to this, which is going to go into the implementation, but just wanted to go over those quick RPM coding CPT changes that came through. Again, we all know that RPM's a good proven way to improve outcomes. The codes are more flexible now. So those 2026 codes, which include, again, 99445, 99470, allow you to bill for those shorter monitoring periods and quicker check-ins. But you must have patient consent. You must meet the data transmission requirements so that you are able to document that you've reviewed the data, that you've communicated to the patient when necessary, and if it required or did not require any sort of change in clinical care. So this is the fundamental kind of first start to RPM. If you are new to this, head on over to the CMS website. We'll leave some references down below. And then in our next episode, we will dive into kind of the practical implementation of how actually to build an RPM program within your practice and some real world examples from primary care and OBGYNs. So as always, if you are enjoying this podcast, we would love for you to subscribe and share it with a friend. It helps us grow and reach more healthcare practices who are trying to stay independent. All right. Thanks so much.